this dosi and, see what happens. So my first patient I'm going to talk about is a curmudgeonly, wonderful man who every time I see him says, "When can I come off that shot, doctor?" He was on our Spartan study, and he went many years without developing metastatic disease. When it was unblinded, we found out he was on the active drug apalutamide. And soon after, his PSA rose to 100, and his bone scan showed 4 new bone metastases. And my resident I said, "Oh, that's such a bummer." And my resident said, "It's not so bad. He can go on Abi or Enza. He has all of his options available." But as we all know, that's not true. So this is actually a slide I borrowed from Joshi, and he showed it earlier. We have 6 therapies that improve survival in metastatic castration-resistant prostate cancer, but practically speaking, our patients won't receive all of those drugs, and some of them are inappropriate for certain patients. They've been moving up in terms of when we use them. As we've talked about earlier, docetaxel and Abi are being used earlier, as is now apalutamide. So systemic options for MCRPC used to be kind of easy, where we used to just have docetaxel. We divided people into pre and post chemo. But then in 2010, we got CRPC and cabazitaxel, which made it a little more interesting, but it was still relatively clear what should go where. Soon after that, abiraterone was introduced, and after that, enzalutamide came on board, and each of the studies excluded the other drugs. So Enza didn't allow Abi and vice versa. And then they were both approved in the pre-chemotherapy setting, and things got more complicated as we realized we had to probably pick one or the other, and patients probably weren't going to be able to be on both. So at least in my practice, we would look at patient characteristics, and if there were heart failure, we'd use Enza, and if there were renal failure, we'd use Abi. So as we know already, abiraterone after enzalutamide or enzalutamide after abiraterone doesn't work so well. So I tell my patients there's a 20% chance that this drug is going to work. At the VA, where I'm interested in cost savings, and I'm sure you guys are too, we give them 2 months to see if the PSA is going to come down, and then just stop it. And as has already been discussed multiple times at this meeting, ARV7 positivity might help us decide whether or not to try the second drug after the first drug. I'm not currently sending any of my patients for this test. I would rather just try the other drug and see if it's going to work or not. And it doesn't seem like it's completely predictive. For example, if you have a positive ARV7, it's not absolute that the other drug won't respond. And even, I know we heard yesterday that while there could be a PSA response, there's not great outcomes radiographically and by survival, but I still think those are very small numbers of patients, and it's hard to make that conclusion. I'm not going to beat you over the head with this. Charted's made us use docetaxel earlier, as did Stampede, and Latitude had us use abiraterone earlier. And in case you missed it, we used this drug until the development of castration resistance. So by definition, once the patient has MCRPC, the cancer is already resistant to abiraterone. So that limits our subsequent choices. Although I'm not saying it's not worth it, because it does improve survival. And Stampede did the similar study, but mixing M1 and M0 populations. So after the development of these trials, our treatment options became less for MCRPC in patients who, and rarely, but sometimes we see people progress on those 6 cycles of docetaxel. Docetaxel later on probably isn't a great option. And after a patient progresses on Latitude, of course, we can't use abiraterone, and enzalutamide is much less likely to be effective. And for people on APA and Enza, again, enzalutamide's not going to be a good option, and abiraterone may not work anymore. So this is an old diagram from a paper in 2015 looking at a swimmer's plot of how we might sequence these drugs. And what's interesting about this chart is it suggests that perhaps in people with ARV7 positivity, we could reverse that by giving some chemotherapy, and suggests that maybe we could try the other agent again, enzalutamide after abiraterone or vice versa. Although I haven't seen convincing evidence that this works, I suppose it is an option. And in our practice, we do try to use Enza or Abi, followed by chemotherapy, and then consider the second agent. And then interestingly is this bipolar androgen therapy, which might also resensitize patients to enzalutamide or abiraterone, not just ADT. And you can see, actually you probably can't see, I can't see very much back there, but the last patient on this list was on nilutamide, abiraterone, enzalutamide before BAT, and then got enzalutamide after and experienced a PSA reduction of over 50%. So I know I ran through those pretty quickly, but I guess I'm leaving it open for discussion.
That was excellent. One of the things, and as you go back, we used to give just for colorectal cancer 5-FU. That's the only drug we had. We gave multiple degrees. You did get benefit in some patients. We just didn't know. We do know in some other tumor types, especially AML, that you can get truly clonal evolution over time depending on what you get. And actually back with Dan Von Hoff years ago, we used to talk about biochemical manipulation. Can I give a drug that then makes the tumor now more sensitive to something I'll do later? Okay. Is that possible? Because you kind of were going back and forth, adding chemotherapy or other things in it. Some of the epigenetic drugs really have the ability to potentially change the phenotype of some tumor. Is that where we should be going now? Again, we focus so much on AR, but should we kind of be saying, okay, AR is critical, but we got to be changing the phenotype to keep it sensitive to an AR inhibitor? What's your thoughts on moving in those directions?
I think at our program, thanks to Joshi and Tom Baer, we do have a lot of those clinical trials looking at epigenetics and other strategies, in that in this situation when a patient's progressing, cancer's progressing on Enza, we put them on clinical trial. So, I think it's a nice concept, but I don't know it's going to work. Yeah. But we should try it.
I was wondering if you or anyone else here is using testosterone or variations of cycling with testosterone in routine practice.
I'm participating with Hopkins on the clinical trial, and on occasion we've gone off trial for people who aren't eligible.
The Transformer trial.
Yeah, the Transformer trial, of which Hopkins is the lead and deserves all the accolades associated with it. And the interesting thing is that resensitization to, it's not just enzalutamide, you mentioned enzalutamide, but also abiraterone. You can resensitize to the agents that were previously resistant. Now, how far can you go? Do you have the capacity to harm? Yes, you do have the capacity to cause harm, and you clearly can cause significant flare. We're not smart enough, or I'm not smart enough to know who benefits and who doesn't. We're trying to maybe a little bit of hint about AR amplification, but that's pretty premature.
I think you're dealing with a heterogeneous tumor population where maybe some of the cells within the population are sensitive to the BAT and others are not, and so it's all about the balance. Are you going to cause more harm than good? How do you find out who's in what's part of the cycle?
Yeah, so BAT is an interesting term because that is the transformer terminology. Yeah. I'm not really sure, and you pointed this out yesterday in a passing remark, which I heard. How do we know what the right thing to do is with testosterone? What's the dose? What's the frequency? Is it IM? Is it transdermal? Who the hell knows? We have absolutely no idea how to use this drug, but it does date back to the 1950s when they've been doing it. There were original studies done in the 50s, high-dose estrogen for breast cancer, high-dose T for prostate. There's a subset of patients that are interesting. We don't know what subset, and we don't know how to optimize the therapy.
And when you do it off study, how do you deliver it?
The cost efficiency of the BAT therapy with the single injection of testosterone cypionate, 400 milligrams, is attractive. The transdermal, where you can, what I've been doing is fixing at 1,000 and just going continuously. We have some interesting, anecdotes. One of which I published. It's hard to know. How do you know what's right when you don't know what's right.
So just commenting on Matt's comment, I have almost 30 patients on the transformer study, and I can tell you some patients respond beautifully.
Yes.
And I don't want to steal the thunder from the results. I have some ideas, but based on Mike Schweizer's original Science Translational Medicine paper he published like 3 years ago on BAT trial, like earlier part of the BAT, 1/3 patients will have PSA decline and radiographic progression-free survival very clearly. We know that. And 1/3 will not have any response. 1/3 will have initial rise in the PSA followed by a decline. So I think half of the patients are responding to high dose testosterone with ongoing lupron therapy. So bipolar androgen therapy.
These are patients who are post-enzalutamide, right? Or are they taking, or is enzalutamide part of the
Post-AVI for transformer.
Post-abiraterone. Transformer is post-abiraterone. And then I have seen patients are allowed to cross over. So enza versus high dose testosterone, that's a randomization, and they are allowed to cross over. So in general, I hardly see any response to enza after abiraterone. Literally, we don't see much.
Yeah.
So
But
Chuck,
patients who have received abiraterone, then testosterone, and then they get started on enzalutamide, much better response.
You
Right.
amplify their AR and then you
Right,
inhibit
but
it.
it doesn't have to be the enzalutamide. You come back to the abiraterone. And there's nothing magic about
Absolutely.
enzalutamide post-T.
Yeah.
It could be abiraterone post-T as well.
Yes.
So
You
Chuck-
resensitize.
This is fascinating, and I think the whole purpose for this study is like to look for biomarkers
Mhm.
of
Right.
who is
Right.
responding. And
Chuck,
I think
this was tried several years ago at Memorial.
Yeah, the men's trial.
So what was the difference? Different disease
That was
states,
hormone
different-
sensitive disease. Remember, they
Yeah.
would take ketoconazole and I think Zoladex and then testosterone for a month. It was like, and that was very rapid cycling. That was called a rapid cycling. So you're castrate for a month, and then normal for a month, then castrate for a month, and they did it like that. And then they did it with docetaxel, and I don't remember what the papers show, but
I mean, it didn't show much,
Nothing.
which is why
Nothing.
there's something different about this recipe or disease state.
it's probably in a more AR amplified setting.
Right. That I would hypothesize, probably the best response I had was the guy anecdotally mentioned yesterday, and he had about a 16, 17-fold AR amplification. And we put him in the high dose T, that went down, this is circulating pre-DNA, and knocked it down to normal. Then he became resistant, put him on ABI again, and had a nice response, even though he'd previously been resistant, and then followed the CFDNA AR amplification back and forth, and it was up and down, up and down. It was really quite intriguing. It was a European urology little report.
Oliver, just a quick question. Are you able to give high dose testosterone off label, like off trial?
I have. I prefer to put it on trial, but of course not everybody fits.
So I always think back to the Manny trial from the 1988, where they gave high-dose testosterone, and they gave CAF chemotherapy as a primer, and that required a screening myelogram because they had a couple of patients develop core compressions. Have you seen people develop rapid progression with this particular regimen? Because that's what I'm most concerned about.
Yes, and so in my own mind, what you need is a runway you need an open runway. If you're going into this with a high volume setting, I think there's really the capacity to cause harm. So the patient that would be more ideal would be the candidate. And Transformer basically has some criteria as well. You don't want somebody who's going to get into huge trouble if they do have a rapid progression. So you need that open space.
I had a question for Julie Graff.
Hello.
No, I mean, I was just wondering, you showed the data that, I guess it was the Azad data where you had people getting Abby, then Dosi, then Abby again and responding. Have you done that? Because I have yet to sort of see that in my world. And nobody's designed a trial to really test that. And one could argue that maybe we don't have the resources to be answering those questions.
I have not ever re-challenged someone with a drug their cancer progressed through. Is that the question?
That's what they say we should do.
I think it's interesting. I don't know. I haven't
All
done it
right,
myself.
so Chuck, I have it. It's very cleanly done, and to have individuals who have had dramatic responses to chemotherapy
Yeah.
resensitized to a drug they were previously
Yeah.
resistant to.
So
And docetaxel is an example, and I'm not going to show you anecdotes, but it needs to be done as a trial.
So this is sort of like the Norton-Simon hypothesis, right? Where that led to AC followed by T in breast cancer. The idea would be that you have two populations. You suppress one, the other one grows. You suppress that. And we're actually talking about doing that if we are ever able to get there with PARP inhibitors when people develop resistance to PARP inhibitors. And we have some theoretical models around that in the PCF Challenge Award. But this slide has been shown for years, and I'm just asking you all as my colleagues if this is something that you do. So,
in other tumor types, I mean, this is definitely, you can do it. You can resensitize. Remember, a cancer cell does not have an unlimited ability to manipulate itself to be resistant. I mean, almost every resistant, and not everyone, but most resistance things are energy dependent. So if you're not putting that selective pressure on it, there's not going to be an advantage for this cell to continue to have an energy dependent, because even a lot of the mutations we talk about are actually less efficient growth mutation, but they actually survive a stress. So again, I think you do see this phenotypic evolution of a cancer cell in many different tumor types, and I think we need to start learning how to manipulate it, but most important, how to identify it. That's
Okay, so
That's
John,
a-
I think and I can move ahead a little bit on the CFDNA, but what does give you a serial assessment of the disease as it evolves, and there's certain things, whether it be AR702, 742, 875, 878 mutations, the amplification, that we can link into resistance to the Abianza class of drugs. That's, I think, pretty clear. Now, I think Kimchi has done the best work here. That said, when you can follow and eliminate, then you have the opportunity, I think, to re-challenge.
correct.
So what we've been doing is to try to eliminate, say, the 875 mutation or the AR amplification, then re-challenge when the resistance mutation has gone away. So is it real? I can tell you in some cases it is. Is this well studied? Hell no. It needs to be done systematically, and we're just exploring right now.
Well, I think that really is a great point, because we really are using, I'd say, very, very loose parameters to determine when a patient is resistant. And also time parameters are really not taken into play. The best example is in bladder cancer. We arbitrarily say that 1 year from the time of chemotherapy or adjuvant and neoadjuvant chemotherapy, they're considered to be, if it's within that year, it's second line. Well, show me the data saying that they're any less sensitive to another chemotherapeutic regimen in that particular setting. In fact, we know that we were fooled years ago with the dose-dense MVAC data that Logothetis published, that the further out you went from your original chemotherapy, when they gave higher doses of MVAC, the better chance you had of responding. So I think what we need is a better biological definition rather than these arbitrary definitions we're using as far as resistance is concerned.
And many, especially when we talk about signaling inhibitors or pathway inhibitors, so you take AR, whatever, is that there can be multiple ways a cell can get around that. If you're blocking something that a cell is requiring to have it grow, it's going to activate other pathways. It doesn't mean that that you don't need to block that pathway anymore. And we have added things on, but so many of the times when we get resistance, we start stopping what we're doing and adding, okay, now I got a MET pathway activated. Let me now target that. But then why doesn't it work? Well, probably because that other pathway then starts stimulating again. So again, we need to, I think, get smarter in understanding the biological principles and how a cell can adapt, and then start targeting that. Again, that's why I talk phenotypic, and that's why I talk epigenetics. I think so many times epigenetics, our drugs are just so crude compared to what they need to be. But, if you can stop that phenotypic change within the cell, it's going to be hard for the cell to adapt to, these selective pressures. And that's why I love to talk, because it really says how you can start sequencing through and get something that's resistant, sensitive, potentially sensitive to therapies. How many more therapies do we need? I think we just need to get a lot smarter in how we deliver them, as much as getting more of them.
But, this general question, I think, of resensitization is an intriguing one. And, I think it really exists more at the anecdote. Nick Vogelsang and Eric Small actually had written a little editorial, I think it was JCO, some years ago. And they talked about this concept. But we've never as a field really grappled with it. I think the Transformer trial is doing a fabulous job of sort of looking at this resensitization, predominantly through enzalutamide, because they're going ABT enzalutamide. But, and I really do want to applaud them for asking the question and really doing the study to get it done. That said, it's the beginning, not the end of the discussion. There's going to be a whole lot more here.
Yeah, I agree completely. And again, as we get technologies that we can assess the cancer in more detail, and again, you saw the 1 in a billion cells. If we can start actually really doing and getting a better handle on really what is different from therapies to therapies, that's where I think we're going to be able to start truly individually choosing it, which gets back then to Dr. Dreiser's talk, which is how do you then design a trial? And again, when each of the possibilities may be small numbers, can you approve drugs off phase 2 drugs in a biomarker targeted that demonstrates a clinically relevant endpoint? And the FDA has been better about that, and I think appropriately so. But I think we're going to have to get there. All right.
I just think about the clinical trial resources that it would take to answer some of these questions that we ask, like, that observation that people get sensitized and can retake abiraterone. Even if we did it in a cooperative group setting, we're asking for a huge amount of space and resource and money to answer this question, and I think it won't get done, but it's an important question.
Well, there was an enzalutamide retreatment study that failed, couldn't accrue.
Oh, really?
Yeah, the eligibility were pretty restrictive, but it just couldn't accrue.
Where was it done? Who was it done through?
It was done.
Astellas?
Yeah.
Yeah. Well, the other thing I think we have to relook at who are the stakeholders for improving these kind of clinical trials. Pharmaceutical companies have their reason they want their drugs on the market, and but there's actually we talk about cost. The stakeholders in that is the government and insurance companies. Mm-hmm. They should be sponsoring these kind of trials. Mm-hmm. If they want to save money, they shouldn't expect people who have no stake in that to be doing it. I think that's one thing too, is you start trying to put the resources. I ought to show you after one of the breaks, but I have a slide. If you look at the total cost of cancer care worldwide is about $100 billion for cancer drugs. Okay, the United States alone spends somewhere about $96 billion a year on beer. Beer. Just beer. Just beer.
Good expenditure.
And not saying that we shouldn't. But again, is that when we look at the numbers, it's not crazy numbers. The question, can we keep doing better for our patients?
I'm sorry, are you proposing a beer tax?
I'm proposing if we all just think about it, if we all quit drinking beer, we could pay for everybody's cancer therapy.
I don't think economics works that way.
or if we all increase our intake of beer, then maybe we'll care less about cancer.
Exactly.
Actually, your stats, the interesting thing, though, that nobody ever looks at is you're investing money in drugs, but how much is that then returned to the GDP in improving quality of life, putting people back to work? That's never cited in any of those statistics.
There's a lot of, and there's, I think, a lot of dangerous ways you can look at things statistically, because then you start looking at age of population. So then you start getting into what is the value of an 85-year-old versus a 65-year-old versus a 45-year-old. That gets really dangerous from my libertarian points of view. But
I actually did some consulting with the Manhattan Institute in New York about these particular issues, and when we brought this to the insurance companies that you should be funding some of these trials, they want to do it on the cheap. They don't want to invest the money. Yeah. That's the whole issue.
Exactly. And despite the fact it could save them money in the long term, they don't want to do it because they think about the next quarter. I mean, again, that's a whole other. All right. So we want to take our break?
Sure.
So we had a